All right, let's get rolling here. So I just want to acknowledge some of my colleagues who helped with this material and cases. And so we're going to start with the esophagus. So we'll start at the top and we'll work our way down in the upper GI tract. So we all have some familiarity with kind of variety of normal appearing esophagus from the perspective of an abdominal imager. In my practice, so I'm just looking at the lower portion of it. So we have the normal esophagus, bulging hiatal hernia, some oral contrast in it, and gastroesophageal reflux here. And some circles, all right. But we also have encountered the esophagus. It's a little too thick, might give us some pause. So in the setting of inflammation or esophagitis, kind of a lobulated, smooth submucosal lesion. This is a benign leiomyoma. And some subtle and maybe not so subtle cases of esophageal adenocarcinoma here with 3 masses where kind of that bright oral contrast does help us to appreciate that thickness. And then the surrounding adenopathy, of course, can tip us off. And then there's the esophagus where there's air where there shouldn't be, right? So this is a case of Boerhaave syndrome where there's a mucosal tear related to repeated vomiting and retching. And maybe you know what comes next after that. They want a fluoroscopic esophagram, right? They want the cardiothoracic surgery team needs to know if there's a tear that warrants surgical repair or if the patient can be conservatively managed. And so this is a patient who came in with a very impressive tear of the lower esophagus and all this extraluminal air. Definitely expected to find something, right? So I took this patient back, did a fluoroscopic esophagram, could not find the leak, but kind of unsurprising. Take a look at that patient's habitus is quite sizable, difficulty with positioning, sick patient. So maybe you found yourself in this situation, felt a little frustrated, wish you could find the leak. And so we improvised a bit at the time and had the patient drink some oral contrast and do a limited CT and found that posterior small projecting contained leak. So unsurprising that you can't find it on fluoroscopy, especially given that it's probably projecting posteriorly here. And then when you turn the patient sideways, there's too many overlapping structures to appreciate such a small leak. So we actually have a formal protocol now, CT esophagram. We have the patient drink about 100 cc's on the table of a mixture of water and contrast and do a CT of the chest. This is a better exam at detecting small leaks, gives you more anatomic information, and it's better for radiology workflow. Here's a patient who had a tracheoesophageal fistula. So you can see some of that contrast going into the left main stem and some within the airway as well. Here's a sagittal view of that exam, and I'm going to label some structures. E for esophagus. Here's that leak, and T for trachea. So you get a sense of that leak going there, communicating with the esophagus. And this patient was treated with a long segment stent and was able to heal up. So this is helpful for guiding management and also provided really a lot of exquisite anatomic detail that I think would be a bit of a mess in the fluoroscopy suite. Here's a patient who had connective tissue disorder and a long segment stricture here and had a post-endoscopy dilation, and they wanted to know, get a sense if they had any tearing related to that. So we were able to confidently look at the stricture, get the length of the stricture, and also exclude a tear. But we don't have to stop at the esophagus. We can actually do a full CT upper GI protocol. And so this broader concept is CT alternatives to fluoroscopic exams. And so we have an esophagram protocol and we have an upper GI protocol. We can look for a leak, either primary leak or a post-ulcer repair, so gram patch after bariatric surgery. We can check for leak and we can look for fistulas. So here's our protocol, which should be in the slides in case you're interested in checking it out. But we found this to be quite effective. So here's a patient who had concern of a leak, and you can just see good opacification of the proximal small bowel and the stomach. Sometimes we'll get decubitus images as well, especially if we're trying to challenge an area. So let's say there's a second portion of the duodenum or duodenal bulb ulcer that was repaired, then we'll do a right decubitus to follow up to really kind of stress that area with the oral contrast load. All right, so now we'll kind of move our way down to talk about the stomach. So stomach can have a variety of appearances based on when the patient last ate or drank. So kind of getting used to that range of normal, and then when you're triggered to say, hey, this looks abnormal. So normal scrunched up, kind of intermediate, thin wall filled with oral contrast. And then we, of course, can encounter a stomach that looks too thick. If your first inclination is to think about cancer when you see this, that's not an uncommon one, but I want to give a couple observations about this case that might make you think otherwise. So when you look at too thick of a stomach wall, think about how the attenuation of the wall is. Does it look more kind of fluid? Is it more intermediate, or is it high attenuation enhancing? So in this setting, this is relatively low attenuation gastric wall thickening. It kind of rapidly occurs at the antrum and then into the pylorus and first portion of the duodenum. And then maybe these are some craters, maybe not. We'll see what they found on endoscopy. So here they found several superficial peptic ulcers resulting in all of that submucosal edema. This is a patient who has more impressive kind of diffuse gastric wall thickening in the setting of acute on chronic pancreatitis. So you'll see that kind of similar pattern of low attenuation gastric wall thickening in the setting of pancreatitis. And also kind of another variation in pancreatitis that you'll encounter will be these dissecting pseudocysts. So pseudocysts are looking for some place to go. These pancreatic secretions, they're going to burrow their way into the gastric wall and kind of form these lobulations. And then here we also have them around the spleen, subcapsular, indenting the parenchyma. This is a more pronounced and alarming appearance of gastric wall thickening related to walled-off necrosis. And the amount of gastric thickening and inflammation in the setting of walled-off necrosis was new for this patient, raised concern of infection, and was treated with cystogastrostomy, and indeed was found to be secondarily infected. Here you can see a little bit of that remaining pancreas tail and dilated duct leading into the walled-off necrosis. Here is a less acute presenting patient who has upper abdominal pain, diffuse gastric wall thickening, submucosal edema, some irregularity of the mucosa that was really quite impressive on endoscopy. And that was Menetrier's disease, which is a protein-losing gastropathy. So it's a chronic gastropathy. And so causing hypoproteinemia, and not a very common diagnosis to make, but something to be aware of. And so we talked a little bit about inflammation. Now we're going to talk about inflammation and air where it shouldn't be. So what you're going to find when you're dealing with ulcers that are either gastric or duodenal ulcers, you're going to encounter air, fluid, and inflammation in a relatively characteristic pattern in the upper abdomen. You're going to find it along the anterior margins of the liver. You're going to find it in the kind of along the fissure and gallbladder fossa. And then if you're giving oral contrast, you might even see oral contrast where it shouldn't be. Here's a patient who had a perforated gastric antral ulcer. Was a large patient, obviously, could not get IV contrast due to renal failure, but did get oral contrast. And hopefully you can appreciate, obviously with the free air in this case, you can make the diagnosis that there's a perforation, but in this setting, you can say exactly where the perforation is. You can see that oral contrast leaking out of the antrum, coating the lower liver surface. Here's another patient who also couldn't get IV contrast, but got oral contrast and admittedly drank what is probably a heroic amount of it, given how much is leaked out. But that does show that defect really well here of the duodenal bulb, and then some of that kind of variable density layering within the enteric contents along the liver edge. Another variation of ulcer to be aware of is a marginal ulcer. So having kind of in your mind when you're dealing with a gastric bypass patient, what are some things that could cause acute or maybe subacute abdominal pain? So these marginal ulcers may or may not be perforated, and they can be really easy to scroll right through because you're going through that upper abdominal surgical anatomy. Okay, the patient has bypass, let's move on. Well, take a really careful look at the gastrojejunal anastomosis. So these marginal ulcers are going to occur on the jejunal side of the gastro-J. You could see in the non-perforated setting just a little bit of subtle stranding like this, and then some dots of extraluminal air when they're perforated. So, but these are often taken back and surgically corrected. So an important diagnosis to make, and one that you only really get a few slices on to do it. So keep that complication of gastric bypass surgery in mind. Emphysematous gastritis is less of an eye test here, right? So really impressive air within the gastric wall, subportal venous gas, and this really nasty looking picture on endoscopy. However, the thickness of the stomach wall and the muscular stomach wall was fortunate for this patient as they were able to make a full recovery. Gastric varices can have a variety of appearances, but have some important associations. This is setting up a patient with portal hypertension and gastric varices. You can see kind of those bright, enhancing varices within the stomach wall. This patient, on the other hand, does not have portal hypertension, but has these short gastric varices along the posterior fundus and a little bit of the gastric body. So short gastric varices, what association can we make with those? Let's scroll down a little bit and see if there's something to account for that. Yes, that's right. Splenic vein occlusion. So this patient has pancreas tail adenocarcinoma, splenic vein occlusion, forming short gastric varices. So just kind of tying that whole picture together. So we talked a little bit about stomach wall too thick in the setting of peptic ulcer disease, and now we're going to kind of talk about the rest of them. So we'll start with our setting of inflammation. Here we have kind of relatively low attenuation on the setting of lymphoma. We'll see that more intermediate, almost like muscular type attenuation of the stomach wall. And then when it's bright and enhancing, start thinking about adenocarcinoma. So we'll show some cases of that. And this patient has that bright oral contrast, which I think throws off your perception of the brightness. Okay, gastric lymphoma. This is again, you're going to look for manifestations elsewhere to help support your diagnosis. This patient had perirenal masses and some adenopathy as well, but we have this really thick, impressive gastric wall. Here it's quite impressive, but again, non-obstructive with that bulky adenopathy in the mesentery. And then this was a case of diffuse large B-cell lymphoma, which I think provides a mixed picture that's pretty illustrative of those different densities. So the concept of cancer and ulceration, or cancer and inflammation in the stomach, is something to be aware of. So don't let the most alarming feature guide you. So there's that soft tissue thickening of the wall, and then there's that low attenuation. So there's ulceration here, and then there's that soft tissue component. So this is lymphomatous tissue, and then there's some ulceration as well. And again, the other manifestations of lymphoma, you'll look for nodal disease, and you might even see bowel thickening elsewhere. Malignancy plastica, or infiltrative adenocarcinoma of the stomach, can have a variety of appearances. It can be related to primary tumor or metastases. This is a patient who had breast cancer diagnosis and rapid progression of diffuse infiltrative enhancing tumor just within a 4-month period of time. And here's a patient with that primary tumor where we're going to see a little bit more reliably that gastroparetic ligament infiltration and adenopathy that'll help us to make that diagnosis. So getting familiar with the gastroparetic ligament, or just kind of what are the major things you look for there. So normally you're just going to see some small nodes, but this area becomes really important in the setting of esophageal cancer and gastric cancer. So here we have, it's not even entirely clear where the primary tumor is, but wow, those are some really big abnormal lymph nodes. And we'll hit on a couple more cases. So let's talk about this case here. So we see stomach is too thick. It's enhancing relatively impressively throughout, although there are some areas of mixed lower attenuation as well. And so is this gastritis lymphoma or Malignancy plastica? One of the key findings here is this thickening of the gastroparetic ligament. So wow, we actually get to see it. It's amazing. And then there's some enlarged lymph nodes as well. And of course, don't forget this little bit of omentum flapping around in the breeze. So this, even this small kind of modest amount of omental disease is enough to make that diagnosis confidently. And of course, carcinomatosis in a more impressive form can be illustrative. So here we have probably the worst omental cake that I've seen, where it's like ribbon-like infiltration of the whole omentum, and then you get a sense in the sagittal that typical like omental draping over the small bowel. Although I'll just warn you, when you're looking at cases of these, you're not always going to see that kind of typical netter-like anatomy, but it can be helpful when you do find it. And then these abnormal mesenteric lymph nodes. And then here we have that primary tumor, which is a mixed density tumor, right? So that ulceration and tumor, which I only really partially show here. There are also less typical manifestations of carcinomatosis to be aware of. Here, the patient has diffuse thickening of the stomach wall, that infiltration of the gastroparetic ligament, but also has some unusual stuff going on. There's the gallbladder wall is really thick and enhancing, and then look at that nodular thickening and enhancement of the common bile duct, very unusual. And then also this implant along the bladder dome. So you will also encounter some unusual or atypical patterns of carcinomatosis, but just be comfortable thinking about that pattern of disease and how it could spread to a variety of places. And here's another example, big bulky gastric mass, really impressive adenopathy, this kind of more nodular infiltration of the omentum, and then finally bilateral ovarian masses. These are Krukenberg tumors, which can occur from gastric or colon cancer metastases. You'll encounter these from time to time. We did touch on this a little bit in the first talk, but efferent limb obstruction. And again, this is a gastric bypass patient, but wow, that excluded stomach or that pancreaticobiliary limb is really dilated. And so thinking about that anatomy again, here we have our dilated stomach, and we're obstructed kind of right at the pylorus. And I think I circle back to that one, but if I don't, let me just mention the cause in this case is an obstructive adenocarcinoma. The patient had a venting G tube placed and then an ultrasound guided biopsy of that. So interesting course of management, but just kind of thinking ahead, with a lot of these cases, it's having a sense of what is going to be the next step in management and keeping the patient's care moving forward. And that's a major thing that informs my reporting in a lot of these cases too. All right, so take a look at this case. Is it going to be cancer, or is it going to be inflammation, or is this normal? So there's a little bit of thickening medially. On axial, it's almost easy to scroll right past that and not make much of it, although on coronal, we get a sense of, this is kind of asymmetric, right? The medial wall's pretty thick, lateral wall's not that thick. Well, this isn't an eye test, because if you scroll down just a little bit more, you get that gastroparetic ligament adenopathy that really helps you to make that diagnosis. So this was a cancer case. And here we have another case. Gastritis or cancer? Okay, so the stomach actually looks pretty good, and we're talking about the pyloric channel here. So take a look at that. What do you think? The intermediate density, and then there is something interesting along the lower margin, is this cluster of lymph nodes. We'll take a look at coronal here. So I think this case, really what it comes down to, okay, so we're into the pylorus. There's some oral contrast, which I think can make these stomach cases sometimes a little bit tougher, because it can make the enhancement a little bit difficult to appreciate. But I would say that's kind of mixed attenuation, and then that cluster of lymph nodes along the lower margin. So hopefully you can see all these lymph nodes. So I think the question really here comes down to, what do you make of lymph nodes like that? Do you think that they support inflammation or a neoplastic etiology? If you think that lymph nodes this big can form from the setting of inflammation, then you're going to be steered towards inflammation. And if you think that actually makes me really worry about cancer, you're going to think a little bit more about cancer. So, and I'll just say, lymph nodes like this are highly suggestive of cancer. So adenopathy around an area of thickening should really make you highly concerned about neoplasm over inflammation. You're usually not going to see impressive adenopathy in the setting of inflammation. That would be an uncommon feature. So, and this turned out to be an adenocarcinoma. A couple other tumor types that we should just touch on to clean up. Gastrointestinal stromal tumor, submucosal mass, various sizes, can have some calcifications within it, can have a pretty big exophytic component as well. Carcinoid tumor of the stomach, this is a rare one, but we do encounter it from time to time. And this is a biphasic protocol. You can see the portal vein is not filling that well. Aorta looks pretty good, and that does help you to see that enhancement nicely. And then this is a setting of a patient with gastric polyposis. Let's now talk about duodenal ulcers. And so a couple of categorical things to think about with duodenal ulcers would be that where the pattern of gas and fluid is going to be. So if you're dealing with first portion bulb, you're going to see more intraperitoneal, and also gastric. So gastric first portion bulb, you're going to see intraperitoneal air and fluid. Second and third portions, you can actually just see retroperitoneal. And then sometimes the fluid and air can kind of dissect into multiple planes. The ulcer defect is often hard to see after perforation. So, and that's because you can kind of think of those coapting edematous edges of the ulcer kind of coming together. And so oral contrast can't help. So consider using that for problem solving. But we're going to start with a non-perforated ulcer. Admittedly not a particularly common diagnosis to encounter, but here, okay, so take a look at the bulb here, and then just watch the medial margin of that sweep. Right along the pancreas head, there's this mushroom-shaped extraluminal inflammatory outpouching. Almost looks like groove pancreatitis at first glance. And we can see it there as well. It's a non-perforated ulcer, but certainly at risk for perforation, and an important diagnosis to make. Also reinforcing, running the upper GI tract as part of your search pattern for these patients, because you may even encounter it unexpectedly in a patient who's on chemotherapy or kind of immunosuppressed and not necessarily mounting an appropriate response to this amount of inflammation and presenting as early as you'd typically expect. So I mentioned earlier that highly characteristic pattern of air fluid and inflammation will guide us when we're dealing with perforated ulcers. So let's keep those concepts in mind. So here we have perforated ulcer. We were encountering air in the upper abdomen right away. Some oral contrast is on board. Really more submucosal edema in a long segment of the first portion of the duodenum than we'd expect to encounter. This kind of intraluminal feeling defect, which actually could be hemorrhage. And then that oral contrast showing us that defect, but actually I'll show you on coronal, which I think is pretty helpful. All right, so there we go. And then you get a sense of that extraluminal contrast kind of leaking out. It's even kind of hard to see the hole, though. Like I mentioned, there's quite a bit of edema and coapting of those folds there, but that oral contrast leaking out leaking out along the lower margin of the gallbladder, and then that upper abdominal air and inflammation helps us to confidently make the diagnosis and guide surgical management and their incision appropriately. In the setting of a second portion ulcer, we are encountering, in this case, only retroperitoneal air. So nothing really in the upper abdomen. And maybe that's not showing up too well, but I did include an intermediate window here. So you get a sense of all that air there. So I think when you're encountering pathology in different planes like this, it can be really great to take a moment and kind of think about, okay, anterior pararenal space, and well, I'll look at is actually pushing up on the colon. So just kind of helpful seeing that, appreciating those anatomical planes. And the ulcer defect is best seen on coronal here. It's right there along that medial margin. So there's that ulcer crater. All right, so that covers the second portion of the duodenum ulcer. And so just as like a broad concept, as you're dealing with these patients and you're thinking about somebody coming in with free intraperitoneal air. So this is supine, upright images, free air. And the question is, what is the most likely source, all comers, of unexpected free air with acute abdominal pain? And, maybe it's just a reinforcement from medical school teaching or what, but I think a lot of us think, oh, it's perforated appendicitis, diverticulitis, bowel perforation. But, keep kind of think back in your practice of the cases of perforated appendicitis that you've encountered. Usually you're finding more localized inflammation that is largely confined to the right lower quadrant. The abscess, or maybe extraluminal air, is confined to the lower abdomen and mesentery, rarely going to the upper abdomen. And if you are going to the upper abdomen, it's usually just a couple of dots here and there. And similarly, in the setting of diverticulitis, you're often going to find it kind of perforating into the mesentery and kind of localizing and walling off within the lower pelvis. So the point being for these two is that, in fact, perforated ulcer is going to be kind of the most concerning and most likely diagnosis to make in the setting of acute abdominal pain and free air, rather than going on kind of a chase to think about diverticulitis or appendicitis. Although for my search pattern, I do like to look and run the whole colon and also check on the appendix just to make sure that I'm accounting for all variables. Oops. Okay, sorry, I'm gonna go back. So we'll talk about small bowel tumors. We're gonna touch on adenocarcinoma, lymphoma, and neuroendocrine tumor. Small bowel adenocarcinoma, not a particularly common diagnosis to make. Here we have a adenocarcinoma here, the second portion of the duodenum. Almost has that similar kind of apple core look of a colon cancer, right? It's this circumferential thickened wall and then some borderline surrounding lymph nodes. Just being aware of that diagnosis, notice the more intermediate or even higher density thickening of the wall rather than that low attenuation edema that we saw in the earlier cases of ulcer. So keeping in mind that the stakes are quite high. So if you're suggesting that diagnosis, or at least considering that it's a possibility, that obviously making that diagnosis in a timely fashion would be extremely important versus potentially conservatively treating for ulcers or duodenitis. Small bowel lymphoma. We showed that case in the first talk of a more distal small bowel lymphoma, but here's one of the third portion of the duodenum. So this big bulky mass. Well, it's not obstructing the bowel, but it is obstructing the biliary tree. You can see it kind of compressing there. And then there's this extension of that soft tissue into the mesentery. I'll show that on coronal as well. So there it is. This is the third portion of the duodenum, this big, bulky circumferential mass. You can see that component of the mass extending into the mesentery, which is kind of a typical thing that lymphoma would do, right? To have those other kind of soft tissue looking like implants elsewhere, and then causing obstruction of the distal common bile duct. This was a B-cell lymphoma. Small bowel gastrointestinal GIST, or gastrointestinal stromal tumor, can be a variety of sizes. So I showed that gastric one earlier. This one, unfortunately, is a bit of an eye test. So we have this oral contrast on board, and then, wow, it's right there. So whether or not the oral contrast helped in this case is a little up for grabs, but certainly impressive, whoever made this diagnosis, because they did catch it on this exam, and it would be very easy just to have this blend in with the remainder of the bowel loops. But there it is, that enhancing exophytic mass with some calcifications within it. So this is a small bowel gastrointestinal stromal tumor. All right, so we have touched on a couple of the small bowel tumors, adenocarcinoma, lymphoma, GIST, and then neuroendocrine tumor we covered in the first talk. much more commonly going to be occurring in the ileum. And so we'll go over some summary points here. So we started at the top, starting with the esophagus, esophagitis, talked about cancer, perforation, and then the utilization of a CT esophagram or looking at CT alternatives to fluoroscopic exams. We moved down to the stomach, talked about gastritis, ulcers, how ulcers can be complicated by perforation, and then kind of like the concept of air where it's not supposed to be, air within the stomach wall, and then abnormal thickening related to Menetrier disease or more of a chronic gastritis. When dealing with a stomach wall that's too thick, we talked about inflammation, lymphoma, and adenocarcinoma, and then those key findings in adenocarcinoma that help us to make that diagnosis, gastroparetic ligament adenopathy and carcinomatosis, and rounding that off with discussions about GIST and carcinoid tumor. And touching on some small bowel pathology, peptic ulcer disease, diverticulitis, which will be covered in the next talk that I give in more detail, lymphoma, and adenocarcinoma. So thank you very much for your attention.